Good morning, everybody. Welcome. My name is Catherine Flug, and I am the Tacoma-Pierce County Opioid Task Force Coordinator. I want to thank all of you for coming to the 2025 Opioid Summit. I am so happy to see everybody here today. This is a great turnout. I'm just so thrilled that all of you are able to be here and participate. A few housekeeping items before we begin. Bathrooms are located here on this side of the room, and then in that back corner, there's a sign leading you to additional restrooms. You will go down the hallway and then down the stairs to the lower level to find additional restrooms downstairs. In the event of an emergency, if we have to leave the building, we can go out the doors we came in, and we can also use this door on the side of the room as an emergency exit. I would like to ask everybody to please silence your cell phones if you have not already done so. And I would like to let everybody know that this event is being recorded. We will have the recording available online in a few weeks. Some background about the Tacoma-Pierce County Opioid Task Force. We are a joint effort between Pierce County, City of Tacoma, the Tacoma-Pierce County Health Department, and Elevate Health. The task force is a regional response to the opioid crisis and works to reduce stigma, improve health, raise awareness, and remove barriers to treatment for people with substance use disorder. We have been holding this annual Opioid Summit since 2018, creating a space for connection and resource sharing for everyone impacted by and working to respond to the opioid crisis in Pierce County. The theme for this year's summit is Continuum of Care, which we'll talk about more a little later. And if you could advance me 2 slides, please. Thank you. Our objectives for today are up on the screen. One more, please. Thank you. Our objectives for today are now on the screen. We're going to provide you updates on the work of the task force and opioid settlement fund projects. We'll be discussing the latest trends in Pierce County and also talking about you, everybody in the room, and how you fit into our theme for today. If you were here last year, you will recall that we had an anti-stigma panel. That panel is back by popular demand this year. And then we have a lot of our day reserved for group discussion. And during that discussion, we'll be talking about the continuum of care and looking at ways to improve our system and our processes. And we'll be exploring opportunities to increase our communication and improve our resource coordination. Our takeaways from those discussions will help inform the future work of the task force. Next slide, please. Now we're going to play a land acknowledgement video from the Puyallup tribe.
It is the land right here that the Puyallup people have lived on since the beginning. This right here is where we are in the world, our homelands.
We work on our ancestral lands. We raise our children who go to school on the land of the Puyallup people.
We acknowledge that the Medicine Creek Treaty was signed for the whites to take our land for their benefit.
Land was assigned to our people. The Caucasians said, "This is your land," and they took that land from us too.
Our land was stolen from us. Treaties were broken.
But we are still here today.
Our people forage for food and materials, we pick berries, we canoe, we practice our traditional ways, and we speak Twelshutsi.
Just as our ancestors did.
We are finished.
Thank you. I like that video. I'm really happy that the Puyallup tribe has that available for us to use at events like this. Now I would like for us to hear from our executive leaders of the task force, beginning with Chantel Harmon-Reed, who is the director of the Tacoma-Pierce County Health Department.
Good morning and welcome. I've had an opportunity to walk around this room, and I just want to say that the energy is infectious. It is a real true commitment of the folks that are here that really want to say that opioids in our community has no space. I want to highlight, where we are with drug overdose and the leading causes of accidental deaths in Pierce County. While overdose deaths are declining in 2024, our most recent data show that the numbers are rising again at the end of last year. It remains vital for people across our country to work together and respond to this opioid crisis. The summit brings together people from across sectors, right? There's people in this room from human services, public health, healthcare, behavioral health, public safety, the fire department is here, our elected officials are here, and so many more, community organizations. It is a testament to our commitment to collaborate together. Today's theme is Continuum of Care, which reminds us that the work doesn't begin or end with any one program. It is a mark of our work in prevention, response, treatment, harm reduction, recovery, policy, and so many other things to make sure that we're learning how we can become more involved and make sure that there's impact in the work that we do. I'm thrilled. Again, I cannot say enough about the people who are here in this room and making this commitment to this work. Today, you're going to learn about the strengthening systems and environments so how we can support people living and working in our county to live their healthiest lives. Many of you are already working in these spaces together with the Opioid Task Force or through other collaborative spaces. You're turning conversations into action to serve the community, and that's what drives our progress. I want to thank each and every one of you for your commitment because this work is not easy, but it's especially essential. I want to also thank the Pierce County, and the City of Tacoma for their continued support in this work, and I encourage you to stay engaged. There's going to be a lot of conversations today. There's going to be panels. There's going to be times where it is a little heavy. There's going to be times where there's joy because we're seeing some forward progress and we're seeing movement. But I want to make sure that we are supportive of each other in this space because we need to make sure that we're taking care of the people who are taking care of the people. And that's going to be a sole emphasis, a huge emphasis that we're going to be placing on the conversations that you see today, the panels, the information that's going to be shared. I am right here, but there are several of our staff members, and I want to thank them for being here all across this room that not only are supporting, but are here to support you as well. I want to make sure that, the work that we do allows you to be able to ask questions, to be able to engage, and really participate so that we know that the work that we do here is going to have a strong impact on the outside. Thank you for being here, and I look forward to sharing with you today.
Thank you, Director Reed. Now I would like to introduce Tacoma City Council Member John Hines.
There you go. Perfect. All right. Good morning. Welcome to the wonderful city of Tacoma. Many of you probably live here, but it's always great to have this event back in the state of Tacoma. It's been a pleasure to be out in Puyallup, but I'm so happy we're here this morning for this important work. So pleased to see everybody who's here today be part of this conversation. This ongoing conversation we've been having for multiple years. It means a lot to me to see everybody here who's engaged. Before I kind of talk more about the gathering, I just want to take a minute to thank the efforts of everyone here in this room. Whew, there we go. That's making sure the mic works. I want to thank who's here in this room. I think, is it cutting in and out? It is. I'm not losing it. Okay. Yeah. So first thing, I just want to start with a thank you, right? And as Director Reed said, this work is not easy. It's not simple. Some days it doesn't feel like you may be making an impact on what's happening. I was thinking today about how I've been involved with this for a few years, and while we've seen success in some areas, there are still too many people dying in our community every day. And while we have to celebrate the successes we've had, the weight is, I think, upon us of all the work still left to be done. When I taught high school years ago, our principal told us this story about, when you think about your classroom and getting students to, pass certain exams, find success. Sometimes it's like, well, I'm good with getting 80% to pass this exam, or I'm good with being successful. He told us this story about, well, imagine a lifeboat. Imagine you're in a lifeboat as a teacher, and you're helping get kids into the lifeboat. He said, would you be okay if only 80% of them got in the boat? And it just reframed, and I think in our minds as teachers, about the idea that that while we can take pride in the 80%, the 70%, the 90% of people we save, there are others out there that we're not. And that truly weighs upon us. It weighs upon me every day. And I know it weighs upon you in this room. And that's why I think this room is very special, because we are all engaged in this work in different ways. And it's opportunities for share our experiences, to share what we're struggling with, to share our hopes, to share our dreams, and to really come together and bring that work. And the other thing I wanted to say is, when I talked last time, a year ago, I said goals were, it was to get us closer to that there's the right service in the right place at the right time. So we think about building out this continuum of care. How are we making sure no matter where you are, there's lots of ways to say this. There's no wrong door, that people meet you where you're at and take you to where you need to go. But at the end of the day, we want to make sure that people in our community, when they need help, the right service shows up at the right time and the right place. And so as we look ahead, to kind of think about work ahead, the thing I would tell you all is, I think we need to continue to try to experiment. We need to keep trying things, doing things differently. Some things are working, some things need improvement, and we need to continue to think about, how could we do this better? What could we do differently? Let's not be afraid to experiment and try things. Because in a crisis, we have to try things. We have to do things differently. And so I just hope that as we come out of this day, and I think about my work supporting this group and supporting the work ahead of us, is I really want us to think critically about, how do we make a difference? How do we try different things to really change what we're doing here? One quote I said last time was, you want to go far, go together. If you want to go fast, go alone. I also just, in my mind, come back to that if you want to go far, it can get really hard. You can lose kind of the emphasis, the energy, if you try to go far. And so what I'm hoping we come out of this day is a renewed energy, some new excitement, some new ideas, some new conversations you have with someone you've never met before, to think about how, as we're to try to address this crisis, we get everybody in the lifeboat. Thank you.
They have asked me to switch out the mic, so I'm gonna see about that. All right, how is this mic? All right, let's just try it. Okay, thank you very much, Councilmember Hines. And now, I would like to introduce Pierce County Council Chair Janie Hitchen.
Well, good morning, everyone. Is this one working? Okay, so I just also want to start with gratitude. My name is Janie Hitchen. I chair the county council, and the first time I attended the Opioid this summit was on Zoom in my office, and the vibe was grim, but the energy behind trying to find true solutions and collaboration, even over Zoom in the middle of the pandemic, was very, very apparent. The people in this room, the people that are maybe here for the first time, and those that are not here right now but maybe are going to watch us later, we care about our community members. We care about the kids that are being impacted by the loss of family members or maybe their peers. We care about the first responders who are responding to overdoses again and again and again and just frustrated. We care about the community members that can't find shelter and can't find help. We care. And that's why the theme of continuum of care is so important today, because we are talking about the path that somebody who is looking for help, somebody who maybe today's the day they want to change their life, or maybe today's not the day, they're just having a rough day, but they're on a path, and we care about that path. How can we help people find a path to thrive in Pierce County? So when we talk about a continuum of care, I really love that idea. We use this for housing. We have a continuum of care for housing. So I was like, hey, it works in housing. Why not have it with our substance use disorder, with our opioid treatment, with how we respond? Because people enter this space in so many different ways. So I just want to acknowledge and thank everybody today as we think about how we can do this together, how we can meet people where they are, and how we can really look at a continuum so that we aren't missing people along their journey, along their path. And thank you for being here. I do want to acknowledge Cindy Wook, who's here from the City Council of Gig Harbor. Obviously, we also met Councilmember Hines, and we have a few other elected officials that truly do believe and care about this work that'll be kind of trickling in as their schedules allow, but truly appreciate everybody that's taking the time to think about, learn, and listen to the work that everybody that's in the room is doing. So thank you for your time and energy and attention this afternoon.
Okay, thank you to our executive leadership for your remarks this morning. Adjust this a little bit. Can folks hear me okay? Is this adjusted right? Thank you. So I want to start my portion of the presentation by looking at some Pierce County data to provide some context for the conversations that we will be having today. These data have been provided by the Health Department's Assessment, Evaluation, and Epidemiology Division. That's a mouthful, so we just call them AEE. So if you hear me say AEE, I just mean our wonderful data team at the Health Department. This first slide shows us emergency visits for drug poisoning from 2020 to 2025. I know that the fine print on this slide is not optimized to be on the screen. That's okay. It's just telling us that the data are coming from the National Syndromic Surveillance Program, and it's also telling us that this captures licit and illicit, and that not all visits are the result of drug use or intentional poisoning. We see here on this slide, the top line in the lighter blue is all drug. So these are visits for all drugs, not just opioids. And then that blue line in the middle, that is opioids. So we can see that opioids contribute to about 1/3 of our emergency department visits for drug poisoning in Pierce County. The purple line at the bottom that has been creeping up over time, that is fentanyl. Fentanyl is currently sitting at about 1/3 of that third, which matches what we know about the drug supply in Pierce County. Next slide, please. This chart is showing us drug overdose deaths from 21 to 2025 in Pierce County. These data come from the medical examiner's office and have been analyzed by AEE. And again, this is all drug, not just opioid. And you can see here, Director Reed mentioned it earlier, we did see a decline in drug overdose fatalities in Pierce County through the third quarter of 2024. And then at the end of last year and the beginning of this year, we did see the numbers start to go back up towards previously seen levels. So far, our quarter 2 data suggest a decline again, but these data will not be finalized until later this year. Next slide, please. Here, this chart is showing us the drug types that are detected in deaths in Pierce County. The green bar at the bottom, that is fentanyl, so we can see that growing over time, which reflects what we saw in our emergency department visits. And then the dark blue bar above the green is stimulants, so that would include things like methamphetamine. The light blue that you see more represented in the left-hand side of the chart, 2021, is non-fentanyl opioids. And so we see over time that light blue has been decreasing as that green increases, again, as fentanyl becomes more prevalent in our supply. The majority of deaths in Pierce County, 67%, involve more than one substance. Of those deaths that involve more than one substance, the vast majority of those are fentanyl and a combination of another drug. What we see most commonly is fentanyl combined with a stimulant, such as meth. Something that we hear in community, a piece of misinformation that we try to counter in our messaging, in our education when we're talking to folks, is there are some people, when they're using fentanyl intentionally, there is a belief that using a stimulant with fentanyl can actually be protective against an overdose. Unfortunately, we know that's not true. We know that it is dangerous to combine substances, and so again, that's something that we really try to push out in our messaging to people. The most common that we see after that combination of fentanyl and stimulant is is people mixing an RX, a prescription, with something else. That could be another prescription, that could be alcohol, it could be fentanyl. And it's just a good reminder for those of us who do education that just mixing any substances is just not a good idea. The other thing that I just want to say, I know that there have been a lot of conversations in the last few years in Pierce County about xylazine, which is also known as tranq. This is a non-opioid sedative. It has been increasingly common on the East Coast. Cities like Philadelphia, Baltimore, Boston, New York are increasingly seeing tranq in their overdoses. Because tranq is not an opioid, it does not respond to naloxone, and there have been concerns about seeing it here. I will say that as of now, we still are not seeing xylazine in Pierce County. We're not seeing it in our deaths, and our partners who do community drug checking are not reporting it either. That's not to say it won't come here, but in case you've been thinking about xylazine, wondering about an update, it's something we still aren't seeing here. Next slide, please. I just have a couple of demographic slides. Drug overdose deaths by gender. We do see higher rates of death among men. This is reflective of state and national trends. And AEE would like me to tell you that we do not have good information on individuals who may be gender diverse. Next slide. And then this is a breakdown of overdose deaths by age. This skews towards older age groups. This is again reflective of state and national trends. And the two highest age groups that we're seeing there at the bottom, that's 55 to 74 years, and then 45 to 54 is our next most common age group. Next slide, please. So I'm going to go back now to the theme for today, continuum of care. And I'm going to talk about what we mean when we say continuum of care, because I think that can sound like public health buzzwords, and it's not. I know that we like our buzzwords, but we are using language intentionally. We mean something when we say this. When we talk about the continuum of care in the context of substance use and opioids, we are talking about services that support people at every stage of their journey based on their point in that journey and their individual needs. Ideally, a strong continuum of care will keep people connected and engaged throughout their process, reducing those instances where people fall through the cracks or fall out of care. It can be really difficult to shift a focus away from short-term crisis. And in this context, short-term crisis frequently means overdose. The priority is really on how are we preventing people from overdosing, which is fair. But we also want to be thinking about, after somebody has experienced an overdose, maybe they're ready to enter treatment, how do we support them in doing that? How do we support them in an ongoing, sustained recovery? And how do we increase our prevention efforts so that the next person who is at risk for substance use or for overdose doesn't reach that point of crisis? Short-term crisis is where the funding is, it's where the media focus is, and it's where community priorities often lie, which is fair. These crises are visible, they're impactful, they touch people who we know, people who we love. But if we spend time and energy and funding on a system that also prioritizes long-term wellness, we can ultimately reduce instances of relapse and overdose, which then circles back and reduces those instances of visible crisis. Next slide, please. So we collected a lot of information from you during registration. You went to Eventbrite, you put in your name and your email address, and you clicked get my tickets, and you thought you were done, and then another form popped up with a lot of questions on it. So if you filled out that form, thank you. We will be using that information throughout the day. And the first thing I want to look at is who's in the room, because diversity of services is important to conversations about continuum of care. We see here, we are well represented from all along our spectrum. We have our prevention partners, we have our harm reduction partners, we have our treatment and intervention folks, people who support ongoing and sustained recovery, and then of course, our funding and policy friends, without whom none of this would be possible. We also have people in the room who weren't sure how they fit in. We have veteran services, we have 911 responders, therapeutic courts, educators, workforce development professionals, people who work with those involved in the legal system, and more. Also, many of you do more than one thing. Many of you fit into many of these buckets along the continuum of care in the work that you do and the services that you provide. Next slide, please. So how much experience do you have? We see that many of you are in your first 5 years in this field, and I think that's great. I said in my opening remarks that our first summit was in 2018, so that means that many of you in the room are new to this work since the task force began and since we started convening annually. This means that we are meeting our goal of continuing to grow the task force and bring in new faces, because it is with the fresh energy, new ideas, new suggestions that we move the work forward and evolve to meet the challenge. I also just want to call out the people in this room who have been here since the beginning, have continually been showing up and supporting the work right alongside everybody else, and we see you and we appreciate you. And then I also just really want to highlight the people who have been doing this work 11 plus years, 20 plus years. As Director Reed said in her remarks, this work is not easy. This work is really hard every day. It may change year to year as the context in which we do the work changes, but it never gets easier. And so for those of you who have been doing this work for such a long time, honestly, I feel like at next year's summit, we should have some of you do a seminar on how to avoid burnout and compassion fatigue to help the rest of us hit that 20-year mark. Next slide, please. So who do you collaborate with? We asked you in our registration form to give us the 3 agencies that you work with the most frequently. I know that everybody works with more than 3 agencies, but we said, hey, give us your most common 3. So then I took all that information, I sorted it out, and I made a word cloud. And if you aren't familiar with word clouds, the more that a word, or in this case, an agency name, is mentioned, the bigger the text. So you see our usual suspects in the middle there. We've got Healthcare Authority, we have Metropolitan Development Council, Prosperity Wellness, City of Tacoma, the county, the health department, Northwest Integrated Health, on and on. But we also have, in the smaller print, so many of the rest of you are represented. We've got corrections up here, we have our hospital systems, we have those public safety partners, we have educational partners. And again, this word cloud is made just from that list of collaborators. And so many of you in the room today are in this word cloud, meaning other people in this room named you as a regular partner. And I think that this word cloud is a strong visual representation of the continuum of care that we already have in Pierce County. We are not talking about building a new system. We are talking about growing and strengthening a system that we already have. Then we asked you where you get your information from. This is a long list. We all get information from so many places. I only asked you, once again, to provide your top 3. I get information from more than 3 places, and I know that you do too. We will be talking about this more later. And I also just want to sidebar and say that several of you in your responses said, I'm new. I don't know where to get information. I would like to know where to get information. And as I was compiling this list, I said, wow, this is a great opportunity to create an information resource. So something we'll be doing as a follow-up to the summit is taking this list, optimizing it with links, and creating a shareable resource. So if you have colleagues who are new, who want to know what listservs should I sign up for, what emails do I need to get, this can be a resource. And I think it's also a good resource for people who have been doing this work longer. There were information sources on this list that I wasn't familiar with. So I'm really excited. Thank you all again for sharing this with us. Next slide. Yes, I am still talking. I promise I will cede the floor after a few more slides. I want to quickly run through some updates of work that we've been doing at the health department that connects to the work in this space, as well as some work that Cheyenne and I have been doing as your opioid task force staff to streamline and support all of you. Next slide. So I want to start the health department updates by highlighting the department's strategic plan. This is a new plan that went into effect earlier this year. And the reason I'm highlighting it today, and I will say you can go to our website, you can see the whole plan, you can read more about it. But the reason I'm highlighting it today is because page 1, section 1, improve health outcomes, the first measure there, measure A, is reduce deaths from opioid use disorder among Pierce County residents by 50% by 2029. This is a big goal. The bullets under that measure are some of the strategies listed in the plan that show how we're going to work towards that goal. And one of those bullets specifically mentions the opioid task force. I highlight this today to show that the task force and this work are priorities for the health department. We will be focused on these activities throughout the length of this plan. We will be tracking our work and holding ourselves accountable. We also this year did an update to our Fentanyl Facts campaign. Fentanyl Facts is a campaign to help youth understand fentanyl. You may remember it from its creation in 2023. It was developed with Pierce County Behavioral Health Tax Funds. Thank you, Pierce County. It was created in partnership with the task force. It was informed by youth. They told us what they wanted to know and how they like to receive information. This year, we received some funds from the state legislature that was passed through to us by the State Department of Health. We were able to update our website, update some of those messages that we've gotten feedback on since 2023, make naloxone information more prominent, et cetera. Next slide. And then we also created, at the request of the Department of Health, a Fentanyl Facts toolkit. So the state said to us, hey, we really like the Fentanyl Facts campaign. It would be great if you could create some templated materials that could be used by other health departments across the state. And this is a partner toolkit. It will be available to all of our partners. There may be items in there that you'll want to use when it goes live. But the primary audience really was those other health departments that may be smaller and less well-resourced when it comes to communication staff or dedicated subject matter experts. Sorry, the Velcro on this thing is attaching itself to me. Get off of here. So in this toolkit, we have videos that have been created, and this was really, I want to shout out the comms team at the health department who put so much work into doing this year. Thank you, comms. This was a short timeline, and they really did an incredible amount of work in a short period of time. But so we have new videos that were created. There's training templates in there. There are fact sheets. There are things like sample media talking points. There's promotional materials, there's templates for social media posts. Some of those promotional materials are here today during a break. If you check out the task force resource table in the room where the coffee is, we've got stickers, we have wallet cards about overdose. You may have seen some of those already. Cheyenne and I have been bringing them to events this summer. They've been very popular. So that's some of the work that we've been doing just to update this and make this campaign more accessible to our partners. Next slide, please. And then finally, I'm going to give you some general opioid task force updates. One thing that Cheyenne and I have been working on this year is communication streamlining. So for those of you who participate in one of our committees, you know that the way that we communicate with committees is primarily through the email lists that are attached to those calendar series. But some of those committees have been meeting for years, and there are literally hundreds of names attached to some of those calendar invites, which means if we send out an email or a meeting reminder, we get 50 plus bounce backs from people who have moved on, the email address has changed, the domain has changed, and that makes it really unwieldy, and nobody else wants to email out to their group because they don't want to get all the bounce backs, they're not sure who they're talking to. So we have been working, Cheyenne has been working throughout this year to clean those up, remove old email addresses, and make sure that the people who are receiving the messages still want to be receiving the messages. I will say this is a great time to mention if you used to be on an invitation for a regular meeting and you've fallen off along the way and you're not sure what happened, you probably missed some emails from Cheyenne. So come and find one of us and we can add you back. And then the other thing that I want to say about communication is we hear all the time that we should have a newsletter, and I agree. So that is something that we have in our plan. We've been talking in the task force leadership and with our comms team about what that's going to look like, how frequently that will be, what the general structure and content will be. But the task force newsletter will be launching soon, so stay tuned for more information. We also have been looking at our prevention and education committee. This committee has done some wonderful work in the past. It has been on hiatus since late last year. And we have been looking at how we want to best use that space because we know that prevention and education are one of the pillars of this work. So we want to be sure that we're using people's time well and that we're doing good, strong work through that committee. I hear from two groups regularly when I am out in community. Those who are providing training or want to provide training on things like overdose, substance use prevention. Maybe they provide training in their community or they want to bring a training to their organization or develop one for their organization, but they're not sure what curriculum to use. If they're already doing training, they're not sure that they're using current information. They're not sure if what they're sharing is based in evidence. Or maybe they just want to bring training resources and they feel like they shouldn't have to develop those from scratch because why would we reinvent the wheel on this topic? And then the other group that I hear from are people who are looking for training. They want to bring a trainer to their organization or their agency on a specific topic in this wheelhouse, but they don't know who to ask. They don't know what that looks like. They don't know if there's a cost. They don't know who's reputable. And we don't have a master list for that in our community. So many of you are providing training and education, and we don't have all of you captured in one place. And as far as I know, you don't talk to each other unless there's a secret other training group that I haven't heard about. And if there is, please invite me. But so we are reimagining our Prevention and Education Committee really as a technical assistance space where people who do training can come together, share this information with each other, share best practices. And then we can also use this to identify gaps in training. If there are topics that people are looking for training on that do not exist in the community already, we can work together to develop those topics and strengthen our training and prevention across the county. So we do have on our resource table, there's a flyer called Join the Opioid Task Force. After Cheyenne speaks in a minute, there'll be a QR code that pops up as well. If this is something you're interested in, please go ahead and scan through to that QR code and just click that you're interested in prevention and education to join the email list to hear more from us as we stand this committee back up. Finally, last but certainly not least, in some ways I've saved the best for last, we're getting a website. Yay! Let's all clap for the website. I know this is something that people have been looking forward to for literally years. Many people in this room have worked to put together resource lists, think about page structure, think about what information we want to capture and share on our website. This website can be a place to house work products for committees, share agendas and meeting notes so that you're not having to search your email every time. We have a vendor, they are under contract. As far as I know, right now they are doing, I don't speak website, they're doing website things to build a website. The timeline has it launching later this fall. There will be opportunities to review it and provide input and feedback before it goes live. So look for more information coming from myself or Cheyenne about that. All right. I said that I was going to cede the floor, and I am. I would like to bring up Cheyenne Keenan, who is going to provide you with some updates on the work that our committees have been doing since the last time we convened.
All right. Hello, everyone. Oh, wow, this is high. I'm short. My name is Cheyenne Keenan. I am the assistant for the Opioid Task Force. If you were hearing Catherine say Cheyenne a lot and you're like, who is that? It's me. So thank you for being here. So the Opioid Task Force is made up of different committees that are a response to different barriers that we have identified within the opioid crisis. And so I'm going to be giving you the updates for the things that they have been doing in the past year. So first up is, next slide please, thank you, is access to treatment. And the committee goal for this is to increase and streamline access to patient-centered, low-barrier, and affirming substance misuse treatment, including medication for opioid use disorder, MOUD, withdrawal management, outpatient, right services at the right time, and residential services. The chairs for this committee are Joe Contras with CHPW and Matt Ehler with Prosperity. So within the past year, we have had monthly updates including member networking. We have expanded the group to include additional partners at the county and state level. Access to Treatment has hosted provider roundtables in 2023, 2024, and earlier this year in 2025, with a focus on brainstorming solutions to common barriers like transportation access. This committee has also been incredibly involved in the planning and facilitating the 2025 Opioid Summit, so thank you all for that. Our future goals include continuing monthly updates and member networking with regular and consistent attendance of substance use disorder leaders and providers, continue to host quarterly provider roundtable events, track impacts of Medicaid cuts, especially in rural parts of Pierce County, implement action items as identified at the 2025 Opioid Summit. So thank you so much, Access to Treatment. We really appreciate you. Next slide, please. All right, next up is anti-stigma. And this committee's goal is to address and reduce the harmful stigma related to substance misuse and people with substance use disorder, SUD, and in recovery. The chairs for this are Allie Torin with Elevate Health and Charnay Ducrest with Tacoma-Pierce County Health Department. So thank you both for that. All right, let me turn my paper. All right, so we have continued to update the Humanizing Language Guide. So this was created by the Anti-Stigma Committee a few years ago. So there is a lot of different language around substance use disorder, and a lot of it is stigmatized. And language is ever evolving, and we need to evolve with it. And so this committee took it upon themselves to create a Humanizing Language Guide. And so this goes over different language that we hear. And so, like, one of the examples is, I personally don't like to use the word clean, because what's the opposite of clean? It's dirty. And so thinking of access into care and everything, like the last thing that you want when you are trying to get care or talk to anyone about substance use disorder is to hear the stigmatizing language. And so we have those at the resource table out in the other room if you are interested. And I also have a PDF file that I can email you. But yeah, so they have created that, and it's beautiful, and it is a living document, so we are constantly updating it. It's going to be on our website as well. So that continually being updated. And we have packed and distributed winter and summer weather kits and naloxone to community members, supported 2024 and 2025 overdose awareness campaigns, coordinated 10+ anti-stigma panels for community members of overdose awareness and town hall events, nursing students at Clover Park Technical College and Pierce College, and at Opioid Summits in 2024 and 2025. Our future goals include expanding access to the anti-stigma panels, develop and promote additional anti-stigma information resources, continue naloxone and survival kit coordination and distribution, collaborate with SUD Lived Experience Advisory Council, SLEAC or SLEEK, on projects and panels. So thank you so much, Anti-Stigma. We appreciate you for all of your work. Next slide, please. All right, next up we have MOUD, Medication for Opioid Use Disorder, integration. And this committee's goal is to increase MOUD integration within behavioral and medical health settings to provide education utilizing telehealth capabilities. The chairs for this committee are Julie Keller with the Salish C Collective and Haley Smith with Elevate Health. And we have been working on supporting development of the SUD Lived Experience Advisory Council, learned from partners about MOUD access in Pierce County, develop resource lists for inclusion in upcoming OTF website. So they have worked very hard on that, so we will hopefully have a lot of resources on that website that you can utilize. We are planning on providing support and feedback for the website, continuing on, and also supporting the expansion of the SLEAC Council. And we're going to partner with Access to Treatment Committee to implement MOUD-focused projects based on action items identified at the 2025 Opioid Summit. All right, thank you so much, MOUD. We really appreciate you and all your work. All right, last but not least is the Lived Experience Advisory Council. And so this council promotes the insight of people with lived SUD experience by providing guidance, support, and recommendations for OTF committees and projects. So there is a lot of voices, and it's very important to have the voices of those with lived experience, because have you ever been at a job where there's orders that come down to you and you can tell that that person has never done your job? and you're like, okay, this isn't gonna work. I don't even have to like try to implement it because I know it's not gonna work. That's what we're trying to avoid. So we have our Lived Experience Advisory Council. They have a lot of input into what we work on, and they have been absolutely incredible in their work. And so they have been working on anti-stigma panels. They themselves are on a lot of the panels, or they will also work on the questions that we ask at these panels. They also provide roundtable participation at the access to treatment provider roundtables, which is also very important. And we plan on resource development for a key audience. So we're going to be working on a lot of that, and also membership expansion. So if you're someone with lived experience and you're interested in this, please contact me. I would love to talk to you. So yeah, if you are interested in that, let me know. And thank you so much to our SLEAC or SLEEK. We have not decided. Everyone says it differently. So thank you so much to all of you. Really appreciate you and all your hard work. So if you are interested in joining any of these committees, we have a QR code there or also an email. Please reach out to me. I would love to hear from you. We also have an interest form that is on our resource table as well. And I also just want to thank all of our chairs and our members and all the incredible work you do. Thank you for your passion, your guidance, and your dedication. The Opioid Task Force is so incredibly lucky to have you. Thank you.
Thank you so much, Cheyenne. We have Pierce County Executive Ryan Mello has joined us and would like to say a few words in support of this work. So he'll come up now. Thank you.
Well, thank you. Well, good morning, everybody. It is so good to be with all of you. My name is Ryan Mello. I have the great honor of serving as the county executive and serving with my friend Chair Hitchen on the Tacoma-Pierce County Health Department Board of Directors. I just really want to thank the Health Department in particular for your longstanding leadership in convening us and helping us move forward in a real meaningful way to really address opioid use disorder and really centering the experiences and the lives of those with lived experience. I also want to thank everyone for your ongoing commitment and not seeing that commitment wane in how we organize, how we center the lives of people with lived experience, and how we continue to work together to really make progress. You know, part of the ways that we make progress is getting the right leaders in place to focus us and really make sure that we're using our resources in the best way possible to maximize, right? And really align our work across multiple disciplines. And that's why I am so thrilled that the county's new Human Services Director, Gary Gant, has joined us at the county. Gary, congratulations and thank you. Would you mind standing, Gary? I suspect many of you have worked with Gary. Gary is no stranger to human services and the major challenges in Washington State and Puget Sound. He comes from a long history of really making progress on issues that face our veterans or those experiencing homelessness and affordable housing and addiction. Gary is a great partner in this work. At a break today, I really encourage you to introduce yourself to him. He is incredibly sincere and eager to meet as many folks as he can and have the department continue to develop relationships. So thank you, Gary, so much for your leadership and sincerity in partnership. You know, I will just close my time. Thank you for being here, everyone. We are truly making progress. You're going to hear more from the Human Services Department and the various work groups through the difference of the day, and we're going to continue to be informed by your thinking about how we use the settlement funds that we have at our disposal to make the most impact, how we use our local dollars, like the Behavioral Health and Therapeutic Courts tax and other dollars that we braid together to make the most impact. So we really are listening. We really do depend on you to guide our work. And we're not waiting to make progress, right? We've so proud of our work with our partners at Metropolitan Development Council to expand detox services from 5 days to 10 days to reduce those barriers. Thank you, MDC, for being a great partner in delivering that work. We will soon be deploying mobile opioid use disorder services around the county, especially in our rural areas, to get at transportation barriers. And again, our Human Services Department is directed to really learn how we can continue to braid the funding that we have available to make the most impact possible, acknowledging that folks are afflicted by multiple issues at the same time. And we have to address housing and substance use and transportation and all of these barriers. And we don't have the luxury of dealing just with one at a time in a silo. So looking forward to continuing to learn how we evolve and how we continue to make the best use of our time and resources to make the best impact that we possibly can. Thank you for giving of your time, your expertise, your passion for the people that we are entrusted with serving, and we're going to make a big difference thanks to all of you. Thanks, everyone.
Thank you. Next up, we have Margot Bernison, Behavioral Health Manager, Pierce County. I also have been asked to remind you that on your tables there is a QR code that leads to a survey about today's event. So at some point, please fill that out to help us plan next year. Come on up, Margot.
Good morning. I apparently brought a cheering crowd in the front row here. Good morning. So we wanted to talk to you about our opioid settlement funds that are coming directly to the county. And I know some of you probably heard me talk last year, so I'm going to do a little bit of background, but I'll try to make it short so I don't bore you all. Next slide, please. So, as you know, in 2022, the Washington State started receiving these settlement funds from different pharmaceutical companies and companies who had supplied opioids into our community. And these funds were kind of put through, and this is kind of that timeline of, they were intended to support the efforts to mitigate the impact of the opioid epidemic. The Attorney General led it. We had some other coordinations like the Healthcare Authority and the state opioid coordinators are responsible for administering those funds to us. And then the state is projected to receive $1.3 billion from various settlements with major opioid distributors such as Purdue or Pharma or McKinsey. However, we also have a lot of smaller settlements coming in all the time, and that's part of what these funds are going to be paying for. Next slide, please. Just again, a little bit of background. So the allocation of the state settlement dollars comes to us. They then, Pierce County started receiving them, and we are supposed to get about $11 million for Pierce County in particular. However, there are other entities that I'll talk about in a minute that get some of those funds as well. That's not part of the $11 million. And then payments are expected to be made starting from 2022. They say for 17 years, which is 2039. However, some of those dates have also been extended out a little bit further. So we're now seeing stuff all the way out to 2042, I believe, is the last date I saw. So we'll continue to get them probably for the next 20 years. The one thing to keep in mind, though, that it is one-time only dollars. So once we get the dollars from those pharmaceutical companies and they're paid out in full, that's it. We're not going to get any other funds. And so I'll talk about our approaches in a minute on that. Next slide, please. Under those settlements, we did what's called the One Washington Memorandum of Understanding. So the One Washington MOU outlines who gets the money, which municipalities get it, and they determine that by the number of opioids shipped to our county, the number of opioid deaths in our county, and the number of people who suffered from opioid use disorder in the municipality. So based off of all of that, we have this very long percentage, but we get about 7.23%, if we want to break it down, of the money coming into the state. That's the percentage that we get for Pierce County. Next slide, please. The MOU itself also indicated how we can use the funding. So for some of those 20 plus folks who've been in public health know with the tobacco settlement dollars and some of those where there was a lot of controversy around how those dollars were used in our communities and whether they were actually going towards the people who were affected. This MOU was created so that we had guidance where we could use that money and we could hopefully stop not using, like, those dollars being used where they're not supposed to be. So this outlines what we use it on. I won't read all of it for you, but it's basically ensuring that the money we get in our community goes to the people who are most struggling in our community. Next slide, please. This is our jurisdiction. So these are all the jurisdictions in Pierce County who are receiving settlement dollars. There is 11 of them, including Pierce County. So you have Gig Harbor, University Place, Lakewood, Tacoma, Fife, Edgewood, Puyallup, Auburn, Sumner, and Bonnie Lake all receive a portion of the Pierce County, that's 7% from Pierce County. Next slide. So in our county, when we were talking about this and trying to set up a structure, we have to, from the MOU, create an opioid, what's called the Opioid Abatement Council. So the Opioid Abatement Council is the one who manages the money. It doesn't manage our money, but they manage the data from what we're using the funding for. And in our county, we decided to have that sit with our, just lost the word as I was saying it. What's that? Auditor, thank you, our auditor's office. And so the auditor's office is the chair and they lead that council with all the other jurisdictions. And so their role is to specifically receive the data from the county, from all the jurisdictions, and then report that up to the state and make sure that where we're using the money matches the MOU that we've stated. From there, you see a couple different things. One, I wanted to break out the opioid task force to show that it is also another entity. We use that a lot. So it's part of the city of Tacoma, Pierce County, the Tacoma Health Department, and Elevate Health. And that is in this room right here, why you're here today, is to help lead us in how we want to use these dollars in our community. And so we're here to kind of talk about that and lead that a little bit more. Then you look over at the Pierce County Human Services. So we get the Pierce County portion of the dollars. We have interlocal agreements with some of the jurisdictions, and I wrote them down here, but you have Fife, Sumner, Edgewood, and Bonnie Lake, who determined that the money they're receiving isn't enough to do something in their communities, and so they asked if they could add it to our funding and have us manage putting something into their community that will be successful. And so part of our role with these entities, these communities, is that we will ensure that services are also going into those communities. I will add, that doesn't mean we're not going to serve other communities who haven't pooled with us, but it just helps us add a little bit more to what we have and make these programs whole. And then under the Behavioral Health Advisory Board, that's who tells us at the county what to do with our funding and gives us recommendations for the funding. So when we're talking about and building things after these meetings and what we're looking at, the advisory board is the one who advises us in those places. Next slide, please. So last year, after this meeting and a group of roundtable meetings that we had with providers and roundtables that we had with people with lived experiences, we came up with 5 priorities, our top 5 priorities for how we want to spend the money, our money, the Pierce County money in our community. And the biggest one we heard were workforce development challenges. as we've heard and as we know, this is not easy work. It's hard work. There's a reason I'm here and not doing direct services anymore, because it's hard. And so we want to make sure that we're building those supports, that we're building those connections in our communities so that people can continue to do the good work that's happening on the ground and making that happen. And at the same time, convincing young people who are out there losing family and loved ones, or who are out there seeing this affect their communities, can get the tools they need to maybe be a part of this community in the future and help us continue to combat what we have coming into our community. The other place where we want to spend money is with the health department, keeping this opioid task force going, keeping this body and this entity that continues to put good work and do good work, and make sure that we're really listening to what our community needs. And then we also do fund a medical examiner, and as grim as that sounds, it allows us to support the medical examiner's office in the amount of overdose reviews and everything they have on their table, so that we can get data quickly and we can know what's really affecting those who die of overdoses. Next slide, please. And as Executive Mello has mentioned, we are doing some pilots on promising practices. One of those is extending our detox, and the other one is putting some mobile units out into our communities. I will talk in just a couple slides about the randomized control trials that we're doing with those studies, and what our approach to this was, and the recommendations we received, because I mentioned these are one-time only dollars going into our community. We didn't want to end up in a situation where we had really good programming for a short period of time, and then it had to go away because the funding went away. And so we really want to make sure that if we're funding stuff with these opioid settlement dollars, that it is something that we can eventually make sustainable. And the way that we can make it sustainable is by doing some sort of evaluation on the programs. And so that's a huge portion of what we're trying to do with any of the programs that we put out into our community. We were lucky enough to get some support from some colleges in the area that I'll talk about in just, I'm getting ahead of myself, sorry. Anyway, we'll talk about that. The other thing we wanted to really focus on when we talk about the continuum is that what we hear the most is the next steps. So we can put somebody in detox, but if they can't go to inpatient for whatever reason, or inpatient just isn't where their next step is, there's not a lot of places where people can go. And so what is the next thing that we're doing once we do an intensive level of care? And how do we ensure that there's ongoing supports? I think, as many of you know, the more times somebody comes up across an obstacle to get support, the less likely they're going to ask the next time when they're ready. And so we really want to decrease those obstacles and look at next steps and look at what step-down facilities can we offer if detox is too much, or if that's not quite where the person's at, how do we meet them where they're at and work with that. And then the last one, which I'm sure is no shock, is trying to figure out transportation and extending transportation. Some of that is with the mobile units and going into the actual communities that are being affected, and some of it is supporting people getting to where they need to be for whatever reason, if it's a court order, or if it's to get to their job, or if it's to get to treatment, or just maybe they need to go to a meeting that day or go somewhere where they can get support that's away from where they're living, then we need to do that. And so that's one of our main focuses. Next slide, please. So as of now, what we've currently funded is the health department. I'm gonna give away how much we give them. We also are supporting the Metropolitan Development Council in doing the extended detox beds. And we're the mobile opioid treatment program, which will be hopefully starting soon. We're trying to get it going. We have received, so I will say that some of the money from the mobile opioid treatment for this mobile unit is from our settlement dollars, and then some of them are actually from federal dollars, where we receive some federal opioid settlement dollars to help us boost this program up into our real rural communities. And then, again, like I mentioned, we pay for a medical examiner. Next slide, please. Here's where I got excited. So we are doing randomized controlled trial studies on both of our projects that we're currently looking at. So extended detox and the mobile opioid treatment program, which is our mobile units. So what has happened is that we actually got a grant from what's called the Abdul Latif Jameel Poverty Action Lab, and their goal was to set us up with somebody who is doing similar research in our country and really connecting us and making it so that we could use and utilize the research that they've already been working on and get more research done. So they gave us this grant for the mobile opioid treatment programs. We have Ariel Zucker, or Dr. Zucker, is an economics educator at the University of California, Santa Cruz. And she really brings actually a much different approach than we're used to as for me anyway, as a social worker. From an economics lens point, she's really looking at things differently and has really helped us think differently about how we can do this project. And so with that, what we've been able to do is move away from doing a randomized controlled trial based off of services, but actually do one based off of locations in our communities. And so what we wouldn't turn people away from treatment. That's never going to be a part of our randomized controlled trials. It's actually looking at where in our communities, when we put these vans, is it working? And if it's not working there, why? And what's happening? And really diving into what's going on that's keeping people from utilizing the service if not. And so she's helping us kind of figure out that way. Her and our data people have a tendency to geek out in meetings, and it makes sense to them. Someday I'll have them come and maybe make it sense to you guys. And then the other one we're doing is with the detox, extending beds. What we're looking at is extending the time that insurance typically covers. And we've had a lot of support with insurance companies willing to work with us with that as well. But this also allows for MDC to stay whole and to keep operating and keeping those beds moving and really helping us increase lengths of stay and seeing if that helps do success rates in people going to the next stage. And so a lot of what's happening and what I think we'll find is that people who maybe have to wait 2 or 3 more days before they can get into inpatient aren't released from MDC because insurance isn't covering it anymore. Instead, they're getting continued supports and maybe even starting some groups and starting to do kind of those stages as detox moves. And then moving straight into detox. And so we're not losing people because they have to go back maybe out onto the streets until they get an inpatient bed. And it's very early, so we don't have a lot of data on that yet, but I'm hoping it's gonna show us some really good stuff. Our plans with these is, again, to help us into the future and help us even going to the state and saying, hey, look, we did these studies and it shows that the insurance days, the recommended insurance days aren't enough. And these are some things that we need. So those are our programs so far on updates. I'm told there's a break right after this. So instead of doing questions, I will say if you have questions, please come find me during the break. And we are back at 10:05, guys. Thanks.
All right, well, good morning, everybody. My name is Elizabeth Allen, and I am the Behavioral Health Policy Coordinator for the Tacoma-Pierce County Health Department and part of the Opioid Task Force. And I am honored today to be the facilitator for the Anti-Stigma Panel. If you recall, when you registered, there were questions, and one of the options you had was to ask a question to the Anti-Stigma Panel. So the questions I'm going to be asking this morning of these wonderful folks have been generated from the questions that were given by you when you registered. So help me give a warm welcome to our anti-stigma panel. I'm going to have them introduce themselves, and then we'll get started with the questions. Colette.
Hi, my name is Colette August. I work for Tacoma Indian Center. We're located in downtown Tacoma. I am from Tla'amin Nation, which is in Canada, and I'm really grateful to be here.
Good morning. My name is Elsa Anderson. I am here. First, I want to say that I am a proud employee of the Tacoma-Pierce County Health Department, and I am so proud of all the work they do in this area. But mostly I am here as a person with lived experience. And I lost my son, Michael, about 10 years ago to opioid use disorder. And so I am here to speak for Michael.
Hi everyone, my name is Courtney Chandler. I also work for the Tacoma-Pierce County Health Department, but I am here in this space right now as somebody with lived experience who is currently in long-term recovery from opioid use disorder.
Hello, my name is Shelby Nyman, and I work for Evergreen Recovery Centers and their unique program called Parent-Child Assistance Program.
Good morning, y'all. My name is Joe Conniff. I use he, him pronouns. I am a program manager for Evergreen Treatment Services REACH Reentry Program. I'm also a person with a lived experience of recovery from an opioid use disorder, and also identifies a person who uses other drugs at times, just not opioids anymore. Thank you.
Thank you so much. The first question is going to go to Elsa. Elsa, what is stigma, and where do you see it in your daily life or practice?
Stigma is with us everywhere, all the time, in all areas of life. The sociologist Irving Goffman highlighted as a process by which an individual with a deeply discredited attribute is socially rejected. Everyone experiences the role of being stigmatized at some point in their life. Stigma sounds like it's a simple thing, but it really is not. It comes through us through different ways. Social stigma, and that's the stigma that individuals hold and perpetuate throughout. There is institutional stigma, that stigma that it occurs in institutions and that create barriers to people getting help. And then there is internal stigma, what you feel about yourself. And that is key, because we have to help people who feel bad about themselves feel better so that they will get help. In my research, I found something that I want to share with you that I thought was extremely interesting, and it is about a study by the Recovery Research Institute. And even in that, I found a little word that I did not like. It had illicit drug use. I scratched out illicit. I don't like that word. But so this was a study where they brought an individual in, and they actually described two individuals. One individual was referred to as a substance abuser. The other person was described as having a substance use disorder. The participant had no other information about these individuals other than the description. The study discovered that participants felt that the substance abuser was less likely to benefit from treatment, more likely to benefit from punishment, more likely to be socially threatening, more likely to be blamed for their substance-related difficulties, and less likely that their problem was a result of an innate dysfunction over which they had no control. and they were more able to control their substance use without help. This is about people's mindset when someone is coming for help, when someone needs help. And because of the words that are used, it changes our mindset about that person. How sad is that? How sad is that? I think of things that I see in everyday life, and I think about words not just about substance use disorder, but about people across a spectrum of places where they need help. You're crazy. You're fat. You're a junkie. Do we really want to talk to people like that? Does that help anybody? I'm here to say that it does not, and that we need to just stop it. We need to stop judging. We need to stop labeling, and we need to start helping. Thank you.
Thank you, Elsa. The next question goes to Shelby. Shelby, what makes people uncomfortable or afraid to talk about substance use disorders?
There are many reasons why people are uncomfortable and afraid. Fear of judgment and consequences, rejection, being negatively labeled. And what I mean by judgment and fear of consequences, I might lose my job, someone might come take my kids. Misinformation and misconceptions. Addiction is a choice. It's not a disease or a disorder. And then labels that can severely affect someone's mental health. Because how often if we hear something over and over and over again, then we start to believe it. And then if we start to believe it, then we start engaging in those behaviors to rise to the occasion. And then fear of confidentiality, especially if we had a negative interaction inside of like the hospital or a treatment center. People were talking about me. I didn't give that person consent. So now my stuff's out there. I don't want to say anything. No, that's okay. If anybody.
All right. Thank you, Shelby. Next question goes to Joe. Joe, why does language matter? And what words are best to use or not to use when talking about substance use disorders?
Thank you. It's a big question. I'll try to be a little bit concise. I'm a firm believer in that the language needs to change so that attitudes change. As mentioned, I'm somebody in recovery, but I also assume there's a lot of people in this, I know there's a lot of people in this room with lived experience. I also imagine there's a lot of people here who, even without a problematic relationship to substances or another compulsive behavior, internal dialogue, and most of the humans I spend time with is already, it can be a pretty treacherous ground to begin with, so navigating other people's personalities and spaces where we're supposed to be able to be seen with our humanity and our dignity, and then we're met with language rather than who I am, and I just become a sum of my circumstances, makes it very difficult. I had a lot of experiences with that, coming out of homelessness that was intersected with substance use disorder, incarceration, those kind of things. And so I always encourage people to just lead with the person first. They're a person before they're anything else. Person living with a substance use disorder, person with a problematic relationship to substance use disorder. For one is, I think one of the most criminal things that people do is cast labels on people without really knowing fully circumstantially about that individual. So, we have a lot of medical language that is trying to move us away from the stigmatizing language, and I'm just gonna name it as somebody who's participated in a lot of community fellowships and things like that. Some of the biggest damage comes from our own fellowships and things like that. The perpetuation of language like clean and sober. I think Cheyenne mentioned it earlier, is the opposite of clean, though we don't always say dirty, but it does show up in urinalysis screenings, is there's an undertone to the flip side of all of those coins. We have to look at the power of language and how it shapes things. I also appreciate the mention of substance abuse, that how harmful that is. You can't abuse an inanimate object. And then what does that do for folks that are survivors of actual abuse at the hands of another human? Is it really blurs those waters, and so we got to look at the reality of the impact on that. It's also just looking at the throwing around of the word addict. That's fine when you say you're addicted to chocolate, but when it comes to other substances and the language gets co-opted, it's okay to say in certain settings and then it's not in others. I think, one of the things that's at the core of this is the reality that we live in a pretty punitive-based society. And so the language we use is punitive, it's shaping people at a distance. And so there's a lot of resources out there. I heard the Recovery Research Institute. We have the humanizing language sheet here within the Tacoma-Pierce County Health Department. I think, using resources, do your own education and check your own biases of like when you see somebody using drugs, living out of doors, what comes to mind? What is the first thing that you want to say about them? Even as people with lived experiences, we do shoot our wounded. I can't stand it when I hear that we don't. We're some of our own worst enemies in our community. We can be the best allies. So, thank you.
All right, the next question is for Courtney. Courtney, what are the best practices for supporting individuals during that small window of motivation for change?
So I think number one is lose any judgment, right? So don't approach somebody with judgment, and use encouraging words, motivation, support them, encourage them, provide that hope, right? And also, most importantly, too, is getting them the assistance at the right time, and getting them connected. So don't assume that somebody has the means to do the things that you might have to do, like have transportation, have access to Wi-Fi, have a phone, to be able to make the phone calls they need to make, right? They may not have those things, and they need those basic things in order to get the help needed. And as somebody who tried from the time I was 19 to 27 to get off of drugs, I tried multiple times, multiple detoxes, multiple recovery centers, multiple methods of trying to detox off of drugs. It took several times, and it took people not giving up on me, and every time that I said I was ready, getting me connected to treatment and making sure that you actually connect somebody, because it is also extremely overwhelming, right? You're already trying to make this huge change in your life and you don't know what direction to go, and so offering options, but not a ton of options, helping them make the next step. How do they get insurance and make sure they have insurance? How do they get to detox? How do they get to treatment, right? Making sure that you're walking with them along that way, along the whole way until they get there. I think one of the things that we need to work on is getting beds right away and getting people into treatment right away. I know that's been a big thing that we've been trying to work on for years, but as somebody who waited 3 months to get into detox or treatment, I was just lucky that I was able to maintain that motivation and didn't die between those 3 months, right? And so also just don't give too much too soon, right? Don't try to fix the entire thing right away. Just ask them what their immediate needs are, and then do whatever it takes to get it, no matter how big or how small, right? Maybe they need a pack of cigarettes before they even talk to you. Okay, get them a pack of cigarettes. You know what I mean? At the end of the day, it's whatever we can do to get people into those doors, and then the continuation of treatment after, right? Don't assume that they go to detox for 5 days or 10 days and then they can get out and have housing. How do you get them connected to housing while they're in treatment, right? And last thing I want to say is not discounting anybody, right? I was homeless on the street in psychosis. It looked like I was not able to get help, and I did. So nobody is too far gone to receive recovery. I've seen people walk out of hell and high water, and they do amazing things for community, right? So nobody is too far gone to get recovery.
Thank you. Colette, talking with youth about opioid risks before they try substances is important. But what can be hard is to know how to have those kinds of conversations. And hopefully we're having those conversations without creating more stigma. How can we start real stigma-free talks with young people?
Thank you. I wanted to start by acknowledging why I'm here. Excuse me. My dad died of an overdose when I was 11, so that was in 1995. 2 years later, my mom died also by an overdose. It was suicide by prescription pills. And so I've chosen to give back to my community and start some youth programming and, really try to be the change that's needed in our community. So I try to let our sacred youth lead the way. I generally will allow them to be the ones to ask the questions and to start those conversations. We'll start these conversations with facts. We'll invite them into spaces such as today. We have 3 of our youth here today, and I'm really grateful, and I feel like they're very brave to be here with these hard conversations. And the facts, a lot of the times we'll start with like the definitions and the very basics of, what are we talking about, and make sure it's clear to them. Kind of like what we were talking about with the language, how important people being able to especially youth, are able to understand those facts that are being shared with them. We had one group that I was part of, I was volunteering in recently, and we were talking about coping, and it was regarding grief and loss, and the subject came up, and so we were able to talk about addiction and opioids at their level. And so, I think that's the biggest thing for me, is being able to identify developmentally where children are and what they can understand. And they can understand a lot more than we think.
Thank you, Colette. All right, it's going to go back to Elsa. Elsa, what can we do better to support families when they reach out for help?
I think the best thing we can do is not judge. I actually, since I got this question, really thought about what help could my family have used, and what did we really go through. And I will tell you, the dynamics of my family is nothing like it was 10 years ago. Prior to this, my family, we are still close, but it's just different. We spent holidays with my sister and her family, because I moved up here to be with her. I love her more than anything else, than anyone else, I believe, except for my son. And as my oldest son began to progress in his use of opioids, we saw less of my sister and her family. We stopped doing Thanksgivings together. We stopped doing Christmases together. It was slow, unnoticed, unacknowledged by me or anybody else, because I was busy being in the depth of what I was going through with my son. We suffered the same judgment that my son suffered. You know he's using you. You know he's using those kids to stay in your house, don't you? Why don't you just throw him out? I don't understand why you can't just do that. It is hard for families. And what we can do best is to support them and know that they need lots of support, because they are going through. I still struggle with this. I struggle with the guilt of not being able to help my son. And I really know I will never really figure it out. I know he knows I loved him, but I also know, although he never told me because the last time I saw him conscious, he refused to have me in that room with him. And I know he was ashamed. Excuse me. And I couldn't do anything to mitigate that. And I don't think I will ever live that guilt down. Because as his mother, I feel like I should have been able to do that. So all I can tell you is just be kind to families, because they're struggling too. And the answers are never easy. Thank you.
Thank you. Next question is for Shelby. What is harm reduction and how does it help people?
This is my absolute favorite question because it's what I truly believe in, even as I've worked really hard with mental health. Mental health is my passion, and it is so, so important because we're meeting people exactly where they're at. And we really focus on keeping individuals healthy, alive, and most importantly, connected to care without the, you have to get no substances in your system, you have to follow all of these important specific steps, or we're not going to help you. I love harm reduction because by meeting someone exactly where they're at, it could be, I'm not necessarily ready to stop. Okay, so we have our naloxone that we hand out, we have our Narcan, we educate, we make sure they have all of the tools and the safety planning that they need and have access to, so at least they're healthy and alive until they might be ready for the next step. Our unique program that kind of helps us do that, if we have a mom who says, I'm not using this substance anymore, but I'm still using marijuana. Okay, cool. Was that affecting your everyday life or behavior prior? No. Harm reduction. It provides non-judgment. It provides trust. And what happens is if those feel safe with us, they don't feel judged, then they will feel more comfortable to do the next step, moving forward and forward and forward. And maybe that is abstinence, maybe it's not. But at least, again, they're alive, they're healthy, and they're thriving as themselves, exactly, authentically, however they want to be, without fear, again, of those repercussions.
Thank you, Shelby. All right, Joe, when someone is actively using substances, what type of supportive conversations are most helpful? Second part of this question, should we wait until they're not actively using before having a more strategic discussion about assistance?
Thank you. Going to jump out at the last part first. No, don't wait. I'll get to that in a minute, though. We can't afford to wait. If you're hearing and seeing the data today, I'll talk a little bit about a couple pieces about getting there. You know, I hear things in my experience going through problematic use and recovery of, you know, people needing to find a rock bottom. I don't agree with that. I've lost too many friends to that archaeological dig that didn't end well. They never made it back to the rooms because of shame, because of stigma of not getting it right the first time, not being able to maintain abstinence, not seeing the value in harm reduction and meeting people where they're at. And I think one of the easiest ways to go about trying to flip the script is, like, societally speaking, we already know what's wrong with substance use. It's peddled and pushed at us from every direction about what's wrong, what's not acceptable about it. But what nobody ever asked me, and when it finally happened, it changed the trajectory of my life and my recovery navigating a drug court program 10 years ago, was what's right about it for you? Nobody ever asked me that. So I had to constantly participate in spaces from a place of demonizing my substance use and things that were my best attempt at solving the problems in my life. And so when somebody asked me what was right about my use, what does it do for you that you don't know how to do for yourself? Like all kinds of bells and whistles started going off. And I said, well, because of betrayal and because of other things. And yeah, like heroin wasn't my problem, it was my solution. And I look at this as so much of our approaches, again, is that they're punitive based, right? Is if you don't get this right, then you need to do this. If you can't participate in this, you're not willing enough. And encourage anybody to think about, and even if you have lived experience, your journey, if it doesn't include certain factors or there's a lot of privilege in there like mine, and still I can tell you that, how are we going to try to punish our way out of something clearly defined by its resistance to punishment, right? Because every day I was in the streets, I was being punished by society, by the law enforcement, by the distance between my family. If it worked, it would have worked by now. We wouldn't have to have this convening and this capacity if punishment worked. And so I think some of the things that we can do with folks, with loved ones, with our community members, with the people that we work with is we can't wait for anything. There's a lot of good stuff along the way. Organization I work for, we do a lot of harm reduction resourcing and conversations with people that are used to being pushed down and shut down by trying to have a conversation about their IV drug use. When we engage with those folks and provide them safer, supportive modes of use or the ones that they're using, we start to get an insight into people's lives and the type of support that they need. But there's no trust if we constantly come at things from a punitive lens. I think about when you have a loved one who's using right now and those kind of things, is community drug checking. That's what we do at my org is people say, no, like folks who use drugs won't make informed decisions. I'm like, well, they won't if you don't avail the services. You'll have no measurable data, but I can tell you every day we have people that bring their couple dollars worth of fentanyl and other things to see what's in it. So when you make the services available, people will access them. And again, as we've tried the punitive model for so long, I think, one of the other things I do want to say too is looking at the harms that are caused by like the hard and soft drug dichotomy of, well, they're using hard drugs, and like a lot of times what I felt that to be like is using cocaine, using heroin, but how many lives does alcohol take every day? And yet we have safe consumption spaces for that all up and down this street, and can't wrap our heads around the reality that consistent supply reduces the drug trends that are killing people in our community. That's a whole nother conversation, but this disbelief that somehow, drugs and alcohol, why do we need to say that? It's as if they're two different things. We have to look at the way that language has gotten us in this mess to begin with, and stigma is all part of the language that we use, the way that we think about people, and the way that it shapes how we see our community. Thank you.
Thank you. All right, Courtney, how can we better promote the idea that taking care of mental health is a form of community and self-care and not a sign of weakness?
First and foremost, by how we talk about it, right? And how we normalize it. And so part of what I do for the health department is prevention work, right? Talking to young people about the risks of substance use and mental health and all of these things, because I want to normalize the conversation. We want to normalize the conversation. It should be as common as your physical health. Do you go see the doctor when you don't feel well? You go see a therapist when your mind is not in the right headspace, right? Like, it shouldn't be stigmatized to receive help, and we shouldn't just talk about it when somebody's in a crisis situation, right? I would love to see mental health checks happen at dinner table conversations, right? I do it with my kids all the time. I would love that to be the norm, right? How is your mental health doing today? I mean, we all struggle with it. And so, but also sharing personal stories and highlighting culturally relevant examples of resilience and elevating voices of youth and community leaders can shift the narrative away from stigma. There's a reason why I openly share my story about being in recovery. A lot of people look at me now and they're like, there's no way that was you. And it was. And if I can change one person's viewpoint of what a suffering, even I got to work on my language because I was going to say a suffering addict, but like somebody who is suffering with substance use disorder, right? If you look at them and you just assume that they are one way, but then you see somebody who's in recovery, who is actually helping community and all of this, like I was that person that was out on the street, right? And who you wouldn't have looked at twice, who you never would have even acknowledged, right? Who you would have assigned those words like she was crazy, she's out of her mind, she's useless to society, she's, all of these things. And I had those labels, right? And really, like what Joe said over here is that like heroin wasn't my problem, it was my solution, because I was suffering from mental health for so long. I was just trying to self-medicate in the only way I knew how. And it wasn't until somebody took a deep look at me and said, hey, you've had some childhood trauma, let's look at that, right? Let's look at that and let's work on that. That then I started to heal and I started to learn new tools and I started to learn these things. And so instead of judging me for the situation that I had gotten myself in, they looked at me as the whole person, right? And that's what we need to be doing, is looking at somebody as a whole person. Nobody is their diagnosis, right? Nobody is their mental health challenges. That is a piece of who they are, and it is something that they already, in their heads, are already, like Elsa said here, they're already struggling and battling with how they feel about themselves. We don't need to be adding to that. And also framing mental health practices like counseling, check-ins, peer support as acts of strength and responsibility and care for both ourselves and those around us helps reframe them as preventative and empowering rather than as a weakness, right? If you know anybody who is in recovery from any mental health disorder or mental health challenge, it takes some strength and bravery and power to pull yourself out of your darkest times, right? That is not a weakness, and that is not a weakness at all. And so leading with that, right? Remembering that the resiliency that takes. And then also, we need to connect the idea to community care. So when I take care of my mental health, I show up better for my family, my workplace, and the community. And when we create safe spaces where people feel supported in seeking help, we can send a message that asking for support is an act of courage and not weakness, right? So even if somebody is reaching out for help, if we don't create those safe spaces where they can actually talk about those things, then it's not gonna work, right? And it's really about shifting the narrative. Caring for our mental health is not a private struggle. It's a powerful investment in both ourselves and the well-being of our entire community.
Thank you. All right, Colette, you have the final question. How do homelessness and opioid dependence intersect, and why is it important to talk about this connection?
Thank you. I chose this question because my younger brother, Chris, died of an overdose on the streets. He was homeless in 2020. These issues exacerbate each other. One is not the cause for the other. We must work on solutions to both, and we must work on them together. That's the reason I'm here today, because I see us being able to work together, find solutions together, find what works, find what doesn't work. And I'm really grateful to be on this panel with these amazing people that have the lived experience to be able to share with me, with our kids, with all of you. And thank you.
All right, this concludes our anti-stigma panel portion of today. Help me thank the panel again for their wonderful personal stories and discussion. We appreciate you very, very much. Thank you. And now we are going to go into a short break.
We're going to get Catherine back up to sort of close us out. But while we wait for her to transition back up here, I just wanted to thank Catherine and Cheyenne specifically. Big round of applause for them. They have done a ton of work to get this ready today, as you can tell, and I feel like it went really well. We're so thankful for them leading that for us, and thankful to the health department. Another round of applause for the health department, just in general. They have been great partners, and thank you to you guys. Thanks for showing up. Thanks for coming. This wouldn't be what it is if we didn't have such a broad group of people here representing different perspectives and experiences in life. And I think when so many unique people show up to one place and put their heads together, it creates beautiful and amazing things. So we're thankful that you came. We are so glad everybody was here and hope that you had some good conversation and some good lunch. And we're excited to take the stuff that was gathered today and continue to partner with the Opioid Task Force to keep moving us forward. And I'm going to give it back to Catherine.
Thank you, everybody. Thank you again to our facilitators for our discussion today. This has just been such a great event. Now we're going to go ahead and move into closing remarks. So I would like to bring our executive sponsors who are still here back to the stage. Beginning with whoever would like to go first.
Good afternoon. I was about to say evening, but we all have the evening before us. And so I want to thank everybody who is here and has done this work with us this afternoon. During our Ending Stigma panel, something that Courtney said really resonated with me. How is your mental health today? And we had some really heavy conversations today, but one of the things that showed up on that last slide was connections and hope. And so I truly hope that you have made some connections, that you have thought about something a little differently, that you have resonated with somebody in the room that you're going to reach out to later and say, hey, I had this idea and you had the same idea. How could we do better in Pierce County? Or maybe the conversation is, I'm really tired. I need to be inspired. How are you doing today? And either of those, at the end of the day, move Pierce County forward, because we stay healthier when we are healthier to be able to do the work. So thank you for your dedication to this afternoon and this morning for the work. And then truly hats off to the health department staff, the Opioid Task Force, the many partners that showed up to plan this behind the scenes, whether it was lunch and showing up early and prepping everything, the materials, all of it. It was really impactful and really meaningful. Just thank you.
All right, so I just really want to echo everything that Janie said here, right? The connections that we've been making here in this room, I feel like it's been an opportunity for us to piece the puzzle together. And I really, really want to give a shout out to Catherine and Cheyenne. When Catherine accepted this job, beginning of the year, right? January, when we first met, I said, I really want to make sure that we understand the through lines. And we need to understand so that we're not tripping over ourselves, so that we are not spending money in places that are duplicative, and just so many other different things. And today, in the conversations that we've been having, the awareness that we've been having, and then some of the things where we're saying, oh, this is where we fit. Oh, I didn't know you were doing these things. Here's how we need to connect these dots, is a testament to Catherine's commitment to step into this space and be able to drive this task force forward. So I know that you've taken a lot of time, right? Everyone who's still here, I really, really appreciate you staying, because you staying gives us energy and fuel to be able to figure out what's the next steps, and then how do we go forward, and how do we do that together, and not just saying we're in this silo over here where it's the health department here doing this, it's the county doing this, it's community partners and NGOs. It is all of us saying, oh, well, we talked to so-and-so and we met with this one and we're going to be partnering up. Just me sitting here in this room, there's about 5 different conversations that I have to have when I walk out of this room, if not more, on where do we go next and how would I follow up with some of you all. And that is a testament to the commitment that you have. I had the opportunity to do a street medicine ride along on Monday. And when we talk about the humanity, when we talk about like the panel that sat up here, those panels that sat up here, it really, it resonated for me because it is, and I believe it was Courtney that said it, they're just dealing with the symptoms. These are not the people who they are. It's just trying to medicate like some of the things that they've gone through. So remembering the people who are at the center of this will allow us to really step into space to be able to meet them where they are. And whatever that looks like. It could be, you know, just as very simple as giving them Narcan. Some of those people ask for condoms. They ask for whatever on their journey. Or it could be as great as like, you know, us getting them to treatment and then being there if they have to go back again. I think about some people who we are helping to navigate some of those processes right now, and my heart goes to them. Yeah, my heart goes to them right now because it is not an easy space in this process. But we need to make sure that we stand in the gap and hold their hands. And like I tell my staff all the time, you're holding their hands, I'm holding your hands too, to be able to help them navigate through that. And that's the only way we're going to be able to get through this together. So I really look forward to what's going to come next out of all of the discussions that we've had today. And I'm really excited about making sure that we continue this progress so that that chart keeps continuing to go down. So thank you so much for your commitment, and I appreciate your time today.
Thank you so much, Director Reed and Council Chair Hitchin. Thank you, everybody, for coming. I know we just keep saying thank you, but I'm just going to say it again. We really appreciate your time today, your energy today. We've really just enjoyed exploring our theme with all of you today. Just great conversations that we had, and we really appreciate all of the hard work that every single one of you does in our community every day, no matter where you fit along that continuum of care. I mentioned it earlier, there is a QR code in the little sign holder on your table. That's a feedback survey for today's event. If you fill that out, it will help us plan our next summit, so we appreciate that. Some next steps. We will be sending out the recording of the summit. I've had some people ask me if we can share slides. We can do that as well. We can share those with you when we send out the recording. And we're also going to create a summary of the key takeaways from the discussions that we had today. So thank you for playing along with us in Mentimeter. I'm excited to get into that later, sort through that information. And we may be asking you for additional input on future work. I know that our committees are all just kind of poised and waiting for the information that we got today. Access to Treatment meets next week. They're really excited to plan the next provider roundtable, moving some of these topics forward. So we're going to be using all of that information and hitting the ground running with next steps and new projects. But there may be opportunities. We may be asking all of you who came today for more information. You might get a survey from me. Just, you know, a little preview of what's to come. I do like my surveys. Please reach out to myself or Cheyenne if you have questions about the Opioid Task Force. Maybe you're here today and you don't currently participate in one of our committees and you would like to. Maybe you're here today and you would like to participate in the revamped Prevention and Education Committee that I mentioned earlier. That's a hint. I'm reminding you about that. Our business cards are on the resource table in the other room. We also will be here after the event. You can come and find one of us. We are always looking for new members and new ideas and suggestions to keep the work moving forward. Finally, I would like to thank everybody who worked over the last several months to plan this summit and who participated in facilitating events or speaking today. That includes our panel, our executive sponsors, everybody who came up here today, and everybody who worked behind the scenes to make this event a success. This would not have been possible without everybody's contributions. So in closing, I would like to wish everyone a great weekend and ask for a final round of applause.